Hi, my name is Hoon Choi. I'm a neurosurgeon at the Cleveland Clinic, Florida. Today we're going to talk about cervical radiculopathy and a surgical approach to fix this without fusion or permanent hardware. Okay, so as you know, cervical radiculopathy is commonly caused by cervical disc herniation, which usually can be off to one side, unilateral, or it can be central. If it's impinging on a nerve root, then it causes the concordant motor and sensory deficits. The most common levels, as you know, would be C5, C6, C6, C7. Occasionally, it could be multiple levels, and it can occur spontaneously or as a result of trauma. So traditionally, after you fail conservative management, which would consist of physical therapy, medications, and avoidance of strenuous activities, you can consider surgical options. The gold standard currently is anterior cervical discectomy and fusion, which is performed through an incision on the anterior aspect of the neck. And then once we reach the cervical discs, these can be removed carefully, sometimes under the microscope, usually under a microscope, depending on the surgical approach, and then can be removed completely, decompressing the spinal cord and the nerve roots. And then the inner body spacer can be placed with an appropriate anterior plate and screws and can be fused. More recently, we have more popular option of artificial disc placement, where instead of placing a static spacer, we put in an artificial disc of appropriate design, and this can preserve motion. However, both of those options involve placement of permanent hardware. And depending on the profession, especially the military members and such as commercial pilots, it's not ideal to have fusion because it can be a career-ending injury and career-ending treatment. So there is an alternative. The alternative is a cervical foraminotomy. This is it's not a new approach. This surgical approach, as you know, has been around for decades, but it's been refined over time, adding minimally invasive approaches and more recently navigation and even endoscope. So traditionally, this would be done through a midline incision and then the subperiosteal dissection of the paraspinal musculature, and a traditional way to approach the spine from the back. This has been now performed in the last 30 years or so with a more minimally invasive approach. So a tubular retractor can be used. And the smallest tubular retractor on the market is a 14 millimeter tubular retractor, which can be then placed after localization with C-arm. And then it can be put in after dilator tubes and docked and performed under the microscope. Now, this can be combined with spinal navigation. So the spinal navigation is a very useful adjunct because a lot of the patients, they have, some people have shoulders, broad shoulders, and it's difficult to visualize the C6-7 level. And if you have to do C7-T1, it's very difficult to visualize with X-ray. Different techniques can be used, shooting lateral X-rays at an angle and doing different collimation and increasing the KVP. However, in some cases, it's simply not possible. So spinal navigation is a very good way to do it. And you can put in a navigated dilator tube and you can lock it and then subsequently put down larger ones and put in a tubular retractor and confirm it. This can also be done with an endoscope, and the endoscope can be done with a traditional C-arm, or in some cases, it could be combined with navigation. Now, the reason why I mention this is because this is I think an underutilized surgical technique. And the advantage of this is that, as we mentioned, we spare the patient of any permanent hardware. And in specific professions, fusion of your neck means that you don't really get to go back to your job. then you have to change your profession or change your career. So now there are some nuances to this. The indications this may be more ideal for unilateral approach, and this can be quite easily done for 3 levels. And if you're utilizing a 14 millimeter tube, it can be done with a single incision. And particularly if you're using navigation, you can plan your trajectory beforehand, and you can use a single incision measuring approximately 1.5 centimeters, and you can access easily 1, 2, or even 3 levels. It is not ideal for patients with segmental cervical kyphosis, or patients with spinal cord compression, and patients with spinal instability. You do have to be careful when you're interpreting the imaging study to see whether the cervical disc herniation is calcified or not. It is our approach to image the patients with preoperative CT to utilize CT to screen for ossification of posterior longitudinal ligament, and then whether there is a better way to fix this, such as an ACDF or artificial disc. And when we're performing this, there are some things to watch out for. So it is ideal to have the patient in a neutral position to a slightly flexed position. Excessive flexion can open up the inner laminar space and can expose the patient to cervical spinal cord injury. So that has to be something that you should discuss with the patient and should be carefully monitored. This can be done with neuromonitoring, so you can watch out for any changes in the signals, and you can run continuous EMG and SSCP, and then do triggered motor evoked potentials. As far as the decompression is concerned, whether it's done with an endoscope or through a tubular retractor, it is first performed by carefully drilling the bone, so the lamina, so doing a hemilaminotomy. So you find the junction between the lamina and the medial facet, and then you carefully use the usually a matchstick drill bit and to do side cutting. You can undermine the surface, you can use kerosene punches, and then the landmarks that you're using is as you go out laterally, you're looking at the pedicle. So especially the caudal pedicle, you're identifying the medial aspect, and then you're looking at the upper wall. And then as the decompression goes on more laterally, you're looking at the lateral border of the pedicle. And then you'll feel the nerve root fall away, and that's an ideal point to stop. Biomechanically speaking, you don't ideally want to take more than 50% of the facet. This hasn't been extensively reviewed in some biomechanical literature. In our lab, we reviewed this, and we found that 50 to 75% of the facet resection is probably the limit in terms of how it changes the range of motion and facet pressures and intradiscal pressure. As you're performing decompression, it is also important to shave the superior articular process. So now this can be done with the drill, but it can be dangerous when you're using the drill directly on the exiting nerve root. So it is our preference to undermine the bone and then to remove it with kerosene punches. Now, if the patient has a soft disc herniation, then some dissection can be performed under the exiting nerve root, between the exiting nerve root and the pedicle, and you can dissect the area in the axilla, and then you can retract very gently, and you can also perform annulotomy. So if there's an extruded disc fragment, it can be removed with micro pituitary rongers, or you can dissect the area and palpate with a nerve hook or a reverse angle curette and free up the disc fragments and remove it that way. And then afterwards, hemostasis is important. Usually the incision, the fascial layer, can be closed with a single ovicral with a UR6 needle. And then the incision, which is usually small, can be closed with any suture of your preference and the glue over it. These patients usually go home the same day. It's performed under general anesthesia, but it's a same day procedure. soft neck brace is an option. They can wear it if the patients would like to. And then narcotic usage is minimal, and patients can then return to usually normal activity gradually, and could go back to work relatively soon. So this is something I think is under taught and underutilized, but something that we should all consider as an option to spare the patient of any fusion and also even artificial disc. Okay, well, so thank you. Any questions we can be directed to NASS, and we can answer in the next session. Thank you very much.